Hey folks, my name is Dr. Amy Pearlman. I'm a board-certified urologist with expertise in sexual, hormonal, and genitourinary health. And I have two guests here with me today. I have Dr. Gregory Broderick and I have Dr. Serge Carrier. Why don't you briefly introduce yourselves, and then we're going to talk about our plenary tomorrow at the AUA in Las Vegas.
All right. You're excited to run them off, please. I'm Greg Broderick. I'm a urologist at the Mayo Clinic Florida. I've been with Mayo Clinic for 30 years now. I've also had the pleasure of serving on AUA guidelines committee since they were established for the evaluation of Peyronie's beginning in 2003, so that dates me a little bit. But there have been 3 guidelines that the AUA has put a lot of time and money in, and we're hoping to kind of share that knowledge with the audience tomorrow.
And I'm Serge Carrier, urologist from Canada and McGill University. I've been on the AUA guideline committee for the ejaculation dysfunction, and hope tomorrow we're going to have a great debate or great presentation at the Las Vegas.
Yeah. And we don't have Dr. Mo Kira here with us right now, but he's going to be presenting with us tomorrow. And let me just tell you what a privilege it is for me to be able to participate with these 3 fine men tomorrow. It is such an honor. So tomorrow we're kind of tackling this topic of priapism, which I don't know that too many urologists get too excited about, to be honest. And the way, it's one of the most challenging things that we do. And I'm going to kind of kick it off talking about a guy who comes in where you do a test injection in the office, and a guy has a prolonged erection. And it does show up actually in the Priapism guidelines on what to do about it. I think oftentimes in those scenarios, if we don't have phenylephrine easily available when we do, let's do a cool compress. Why don't you go in that other room and take care of it? But when you have a busy clinic, that's kind of awkward. I'm not trying to have my patients ejaculate in my clinic, right? So we're going to talk about how do you take care of that patient in an efficient manner where the patient doesn't then show up to the ER with an actual priapism, and where he's not waiting around in our clinic room for 5 hours. And then you're going to take it over from there.
Yeah. Well, I think it's probably most of the worst case scenario when you have priapism and dermomedical issue. If you have your patient at your clinic and you send him home and he said, okay, maybe it's not that urgent to go to the emergency, you may be in trouble the next day. And that's when I come in, I'm going to do the guy who has 12 hours priapism, and what do you do in emergency? And I think it's easy to take care of it, but you don't want to delay the treatment. That's when you get into trouble. And unfortunately, you may reach the time where you need a surgery. So that's why you want to avoid it. So be there tomorrow, because I want to show you how to avoid to go to that limit, extreme limit clinical issue.
So Serge, you're absolutely right. It's a rare problem, but it's a problem that when it arises, it's an emergency. And you must have a strategy for dealing with the emergency. I've been training residents for quite a few years, and the texts and the calls that I always get are not about the common thing, like how do I handle a mid-ureteral stone, but hey, I've got this guy, he's in the emergency room, they can't get the erection down, what do I tell them to do, and then what do I do myself? When does that patient need surgery? So our lecture is around a case-based presentation, and Dr. Pearlman's going to start out with the most common scenario. You're giving a diagnostic injection of trimix or alprostadil in the office, and the erection is lasting too long. Now, if that patient goes home and decides to go to sleep with that erection, then Serge is going to handle what happens when he comes into the emergency room at 12 hours. And finally, Dr. Carrier is going to talk to us about when surgery is necessary, and that's for an erection that's persisted as long as 24 hours. From a medical legal standpoint, I just want to let everybody know that the first thing you need to say to the patient when you meet him in the emergency room is, "Sir, I'm sorry this has happened to you, but you need to understand that this episode of priapism all by itself may result in permanent erectile dysfunction for you. And I'm going to try and reverse it and do my best to reverse it. But there's already been ongoing tissue damage with each hour you've had this erection lived. We call priapism greater than 6 hours."
Agreed. This is why it's so important that the patient is not left in the waiting room before you start to do anything.
I think the interesting thing too, and I couldn't find this online, but it's we do even just like a test injection in the office, right? I mean, tomorrow we speak of this plenary, we're going to be in so many ways preaching to the choir, right? And so we always have this conversation of, well, who are the other healthcare providers that are giving penile injections? And it's kind of like the urologist versus the men's health clinic, you know? And I think that brings up this discussion of, rather than criticizing the men's health clinic, because there aren't enough urologists to treat all the men with ED, how do we collaborate with the men's health, people in the community? And it's interesting because now that the GLP-1 compounded medications are no longer legally going to be provided by these online pharmacies, what do we think is going to happen? I think they're going to delve into sexual medicine. I think we're going to see more online clinics that are offering trimix. What do we do about that?
In some ways, we're kind of victims of our own best guidelines, because many years ago we said that the average ED patient is 50 years of age. He has one of several risk factors for ED, hypertension or diabetes or coronary artery disease, or he's a smoker. That patient doesn't need a big workup. He needs a trial of an oral PDE5 inhibitor. Well, along comes COVID, and what happens? The medical relationship transitions to an online relationship. Now patients can get their online prescriptions in the privacy of their home with a PDE5 inhibitor. Now, thankfully, unless PDE5 inhibitors are combined with cocaine or an injectable, they don't generally
So just Priapism.
They don't generally result in priapism. But unfortunately, when we do diagnostic injections in the office, or we're teaching patients injections, prolonged erections do result in. Years ago, I decided I didn't want a bunch of men sitting in the office with newspapers on their laps, waiting for their erections to come down. So I just started reversing them at about an hour and a half after a diagnostic test. And it worked out quite well. I mean, there weren't patients having hypertensive attacks. The erections usually reverse with the first 100 or 200 micrograms of phenylephrine, and you have a happy patient, a patient who's not embarrassed, and you can move the patients through your process in your office more readily. And it's
People can actually read the newspaper.
yeah, and a lot of this, as Amy pointed out to you, is knowledge that we stumbled upon. I had a very interested resident who was interested, said, Dr. B, some of these patients do end up in the emergency room. How about we look at the time stand for when you gave the shot to when one of the residents actually had to see them in the ER, and then we draw the blood gases. And wouldn't you know it, the PCO2 going up, the PO2 going down, and the pH becoming more acidotic is a direct function of time. So within a matter of 2 to 3 hours, the corporal environment has drastically changed. And that's when we hit upon the idea of just reversing patients in the office and not telling them not telling them to go to the emergency room.
This is when my presentation, all right, because then you need, if you have this patient that has a prolonged erection and you aspirate and it's pretty, very dark red, you need to aspirate until it becomes, bright red, because then there's more oxygen, pH is better, and phenylephrine would work, because phenylephrine doesn't work when the PO2 and pH is low. Yeah, it's very important.
Yeah. So, Amy, I think you said it best. I think you said you have to own this process. So it doesn't matter whether it's a urologist doing erectile testing in the office with a shot of valprostrol or trimix, or it's a men's health clinic prescribing trimix to patients who have failed PDE5 inhibitors. Own the process. That means you don't send the patient out with a prolonged erection and tell them to go home and have sex with his partner, or put some ice on it, or take a tablet of Tesorinate or any other over-the-counter preparation, because those things don't effectively and reliably bring down the erection. Reverse that erection before he goes home. And the other thing that prolonged erection tells you is you need to titrate down his dosage if he's going to be using the medicine at home. Because in your office, the patient's anxious. And if he's getting a 70 or 90-minute erection with the dosage you've given him, you can predict that that's going to be a prolonged erection at home as well. So reduce the dosage.
Awesome. Well, I'm so pumped for a plenary session.
It's going to be great. Don't miss it.
Don't miss it. Thank y'all for tuning in.